So my name is Ariel Kaen. You know, I'm from Sevilla. This is part of the city that you are going to visit next year. So this is a church that has an Arabic and Catholic origins. The place that is in the upper part have many movies, especially in Star Wars movies, because it's a very amazing monument, and this is the gold tower in the river, so you can enjoy the city. So please visit next year to the ESUBE. So we are going to talk about a novel classification of the contralateral approach. We always talk about contralateral, but nobody know the real boundaries, the real limits of how we can do it. So remember that we have three different, as introduction, we have three different approach. We can do an interlaminar approach, that is an ipsilateral approach. We usually can do a paraspinal approach, that is a transforaminal approach, but also we can do a contralateral approach. That is amazing because you can decompress the opposite side without damage the facet joint too much. And especially, it's crucial when we try to decompress not only the lateral recess, but also the foramen. And in some case, the extraforaminal area we can access from the contralateral side. So for that, we are concerning about different names about the contralateral area, and what exactly we need. It depends of the patient. So we are going to classify in three different approach. The sublaminar approach, that is very frequently, and we talk in this a couple of days before. An interlaminar approach that is very common in the uniportal guys, and of course a translaminar approach. So when you read this classification, say, "Oh, this is not new. This is not novel." But what is exactly the boundaries? What is exactly the limit between a sublaminar, an interlaminar, or a translaminar approach? So when we have to choose a sublaminar approach, what we are looking for, what's the pathology we need to decompress? So first of all, we need to do, in the sublaminar approach, a lower portal. So you need to do 1 centimeter lower in order to get better to the foramen. So a sublaminar approach target in our classification, if we draw an imaginary line that crosses the middle part of the disc, all the pathology that is above this imaginary line, you can access only with a sublaminar approach. So all the problem with the tip of the superior articular process, all the problems with the kinking of the pedicle, or the hypertrophy of the flavial ligament in this area, or the hernial disc, and especially the upgrade migrated of the lumbar disc herniation, are fantastic to do the sublaminar approach from the contralateral area. So this is the target, but how we can do it? So remember this illustration for the over-the-top technique, in the C technique. So when we have to understand that to do a sublaminar approach, we need again to understand what is the inner point. Remember, this is the cortical part of the base of the spinal process that is the same as the spinolaminar junction from the contralateral area. So the sublaminar approach is going to be an access from the inner point to the upper attachment of the deep layer of the flavial ligament. If you only drill and get from this side, you can access to the foramen of the exiting nerve root from the contralateral area. Let's see one example. This is a patient that has a lumbar disc herniation and a very important kinking and damage with the supraarticular process. So now we are contralaterally. We have been drilling all the inner point and all the sublaminar approach. Now with this osteotomy, we are trying to remove the tip of the superior articular process from the contralateral area. We are in the left side. Now we are decompressing the right side. So all the foraminal pathology or the exiting nerve pathology we can do with a sublaminar approach. Now we can access to the axilla and the lower edge of the exiting root. And it's not sometimes easy. We have to remove the base of the spinal process, but sometimes we can remove the disc of this area. You are going to see how we can put an Indian knife and open the disc. And it's very interesting when we have an upgrade migrated of lumbar disc herniation that push the root upward, and you cannot access ipsilaterally very nice. So the second part of the classification is the interlaminar approach. And this is very important to understand that depends of the collapse of the disc. Because if you have a very important collapse of the disc, the interlaminar windows is very close, it's very small. And if you have a young patient, you are going to have a very big interlaminar space. So in the interlaminar contralateral approach, you can do the portal in the same way. And the pathology that you can access is two imaginary line. The upper imaginary line is in the middle part of the disc, and the inferior imaginary line is in the lower edge of the pedicle of the contralateral area. So you are going to remove all the transversing root pathology or the lateral recess pathology, to all the pathology that is medial to the pedicular part. So depends, remember, of that, depends of the interlaminar windows, and the especially bone is not the inner point, it's not the sublaminar approach. You need to remove this part of the most medial part of the supraarticular process and the upper edge of the lower lamina, that is the G point. And to understand that, remember that you have to remove the superficial layer. So now we are contralaterally, and to remove this superficial layer, we usually use the dissector always from caudal to cranial in order to split the floor ligament and to see the G point, that is the connection from the supraarticular process to the lower edge of the lamina. When you remove this superficial layer, now you can access, or you can understand what is the G point. It's not a sublaminar approach in this foramen. We are doing to decompress the transversing root. So this is an example. We are now trying to remove a lumbar disc herniation in the lateral recess. We are in the contralateral area. This is the base of the superior articular process. This is the upper edge of the lower lamina, the AIP. So now we are removing this part of the G point, trying to increase our approach. Sometimes we only need to remove only the superficial layer. We not remove all the deep layer. This is a recurrent case of lumbar disc herniation. And now we can touch the pedicle and we can remove the disc. This is wonderful when we have a downgrade migrated of lumbar disc herniation from the contralateral area that is higher from the pedicle. So if you go ipsilateral, you have to drill to match the lamina. So now we are trying to decompress the transversing root. And this is an all disc. And now we can remove more disc. This is a very hard disc, but we can decompress. This is the G point. This is all the decompression, and we can be decompressing very well. So the third step is the translaminar approach. This is very unuseful to do because the translaminar approach is to decompress the lower problems, the adjacent levels. So we are going to do a translaminar approach when the patient have two different pathologies, a lumbar disc herniation in the upper part and a problem or upgrade migrated from the adjacent lower level. So a translaminar approach have two different issues. So you not need only to identify the G point, but also you have to understand what is the base of the spinal process of the lower vertebra, because sometimes have angulation, have such its very cortical part of the bone. And the second issue that have a translaminar contralateral approach is that this part, we are not going to find the floor ligament. This is the part of the lamina that we don't have even the deep layer of the floor ligament. So we recommend not only to drill the base of the spinal process, but also drill this part of the bone always with a diamond burr in order to be careful that we are maybe not find the deep layer of the floor ligament. So remember that the target is all the pathology of the patient that have pathology below this imaginary line of the lower pedicle. So this is a crushing syndrome. So it's a patient that have problem in the L4, L5, and now we are going to decompress L5, S1. So we usually use this diamond burr, and this is the problem that the same root have a lumbar discernition here and some fragment here that touch the nerve in two different parts. So we do a drilling and a paper thing of the cortical part of the bone. After we remove that, we can follow the transversion route, transforming next sitting root from the lower level and try to decompress two levels from only one incision. This is an amazing video from Dr. Parks, not mine, with an example of how we decompress. This is the pedicle area. We usually use here 30 degrees endoscope. And in the final part of the video, even we can see for the trajectory from the 30 degrees, the ganglion of the L5 root of the contralateral area. I don't know if you see all the root here. That is the ganglion. So we decompress the level that we decompress and the adjacent lower level too. So the conclusion is very easy. We need to more detail of the nuance of how we undo it, the contralateral approach. We can select a sublaminar, an interlaminar, or a translaminar approach, depends of the patient. But most of our patients have, for example, central canal stenosis, and you have to combine sublaminar and interlaminar approach. On some patient needs a translaminar and interlaminar approach. So you have to choose, depends of the case of the patient. Thank you very much.
Thank you very much, Ariel. Is there any question from the audience? Ariel, you use a lot translaminar, contralateral. It's very specific, and I think it's very utile, these three differentiations. Because we say everything is sublaminar, not everything is sublaminar. The technique of the contralateral approach is different.
We're looking for this classification, and all the people say sublaminar, look at interlaminar, but translaminar, but it's not the same the translaminar ipsi, yes, that it translaminar contralaterally. We talk in Portugal, it's ipsilateral translaminar.
Yes.
So there are a lot of...
I'm saying that because I'm a fan of the ipsilateral translaminar.
Yeah.
In some cases, but primarily in those cases that you have not only an herniation with a migration, but a sequestration, a local that you don't even have to open the disc. You go straight away, you do just a little square in the lower lamina, and you go directly till the nerve root. Because you don't even have almost yellow ligament.
Absolutely, absolutely. So I don't have very many cases. I have only 5 cases in my series. This case is not mine; it's from Dr. Park, and because it was amazing how the root is seen down. I have most of my cases are translaminar ipsilaterally, but contralateral is amazing too. But you have to. This is amazing when you have pathology in 2 adjacent levels. Yeah. So if you have only from one level, I use a translaminar ipsilateral. Okay.
Of course.
Oh, more question.
You have your own.
Yes,
personalized.
I love to use the left hand. It's changing my contralateral approach. My left hand take time to skill these left hands, but it's going to help me a lot. Sometimes I put the flower ligament. I don't have to remove it because you have retracted, you don't see, and you only need to be careful that not damage the dura about also. I think that the best tip is you must remove the superficial layer in order to have more space, and you not need to drill too much bone, but depends of the case, of course.
I'm a very big fan of RUB. I'm a big fan. Can you tell me differences in your style that for a certain indication, a certain pathology would favor more this approach than para-UBE?
I love para UVE a lot. The problem is sometimes depends of the case. I think contralateral is amazing when you have pathology that is medial to the ganglion, and paraspinal approach is amazing when you need you have pathology ganglion outside from that. The problem is that not in all MRI you can identify the ganglion, so that's the big issue from most of the MRAs. So, for example, if I have an exiting root problem, and you have to do a sublaminar approach. This is maybe the most big issue. So, depends of the level of the lumbar spine. In the upper lumbar spine, because you have a more wide lumbar space, I prefer a paraspinal approach. And in the lower spine, I prefer a contralateral approach because you are far away from the lateral recess. So it depends of the case. I don't have a strict rules for that. Sorry.
Yes.
Yes, you can make it all the portal that you want. The problem is not the portal. The problem is not to damage soft tissue and to target and to decompress correctly. This is not the problem. It's uniportal, biportal, multiportal. I think the concept is to not damage soft tissue and decompress correctly your patient. So, for example, two-level adjacent decression syndrome, you can do it to another approach if you don't have big skills, and you are going to have the same result. But maybe you need to start again. You have to create a portal, and with the translaminar approach, you have to move to change at 30 degrees. You start with 0 degrees, and you can decompress very fast.
Does anybody has any questions? Just responding to Demetrius, I really love the paraspinal approach, but in these cases, most of our cases, for example, foraminal stenosis, lateral recess stenosis, 4-5, I don't use it. Because I think in the lower part of the foramen, or you take out a lot of the sap, or you can't see properly the descending nerve root crossing the medial border of the lower pedicle. I think you can decompress the lateral recess in the upper part really well, in the paraspinal approach. The lower part, at least for me, it's more difficult to advance. But in the lower lumbars, yes, levels. So we'll
Next
progress.
meeting, I'm going to talk about that. We are working about a classification of how when we need to choose the paraspinal, especially in lumbar disc herniation, upgrade, depth, downgrade. We are now working in that. So I hope in February I can choose our result. But we are concerned about, so we are working in that. Okay.
Very well. So